Hello, everybody. Here is Abhinav Yusri, the editor of International Association of Dental Students, IADS. Welcome. It's my pleasure to present to you today speaker Dr. António Pedro Silva, born in Portugal and currently working in Belgium. He has focused mostly on pediatric dentistry and therefore a founder of Pediatric Dentistry Forum. Today he will present us a topic named Dentistry with Children, Congenital and Behavioral Psychology. Please enjoy this very inspiring lecture. Welcome, Dr. António. You can go.
Hello, Abhinav. Thanks for
this
invitation. I'm very happy to be here with this so interesting and important association. I think that is very important for students to have such representation. We will talk today about pediatric dentistry and specifically about cognitive and behavioral psychology. The goals of this presentation are understand behavior management as a dynamic and structured intervention, stimulate the study of cognitive behavioral dentistry, and stimulate analytic capacity. I already was a student. I started my graduation in 2000 and I finished in 2007. During this graduation period, I also studied dental tissue engineering as a researcher trainer, and I also did clinical residence with the first implantologist in Portugal, Dr. Manuel Neves. And after finishing my graduation, I understood that prevention is maybe more interesting than regeneration as a concept. And I created a dental show. I created a toothbrushing choreography and a structurized music and a scenario, some toys, in a way to help children in schools to implement a collective memory. In this period, I understood that I had some kind of competencies to work with children. So I started to study pediatric dentistry as a pro-graduation studies in 2010. And I started with a program during 1 year. And after that, I started a 3 years program. And during this period, as a student, as a postgraduate student, I also created the Pediatric Dentistry Forum because I'd like to be in contact with other colleagues, to know other study models, to be sure about the gold standard in pediatric dentistry. And today we are a big community with 16,000 members worldwide. In 2015, I studied cognitive and behavioral therapy for children in a post-graduation program. But before to be a student, I was a child. And as a child, my worst nightmare was dentistry. I had a big fear, maybe the worst fear in my life. And for me, it's too curious to be here today to talk about psychology, to talk about behavior management. And we know this happened not only with me, because sometimes pediatric dentistry doesn't mean the best part of a children's life. Even with adults, we know that almost 5% of adult population has dental phobia. In a recent study that had a big impact in the community, the study showed us that 24% of Holland population have fear and a big dental anxiety, and half of them suffer from symptomatology of post-traumatic stress disorder with intrusive thinkings and affectation of quality of life. So, related to the impact of extreme dental anxiety, we have poor oral health because people with this condition avoid personal and professional dental care, and because of that increase the risk for general health problems, as we know, and also can affect sleeping and feeding. At the cognitive level, people with this condition have more fears, depressive states with negative thoughts and crying episodes, also a sense of inferiority that is associated with extreme dental anxiety, and at a social level can affect job and self-esteem. So it's a very impactant condition that begins mainly during the infancy after dental treatments. And for me, as I was a child with extreme dental anxiety and as a pediatric dentistry professional, I don't want to be the cause of such problems. And because children are special beings, a lot of poets, philosophers, gods from heaven have been advising us how much important are children and how much they are special. What I can say related to my experience is that my quality of life was really improved by working by children. I got a lot of learnings and earnings that I take them from life for life. And as a child caregiver professional, it is very important to be conscious about the importance of early childhood experience in general and how they can affect children's growth. Early childhood experiences have the importance to modulate children's development in several levels. I'd like to show you a video about this importance. It is a very interesting video from Harvard University, from the Center of Developing Child, that works a lot with stress in children. So I'd like to show you this video.
What if you could take action to reduce crime, improve health and education levels, increase family incomes and state revenues, and improve the quality of life in communities throughout your state? Where would you begin? Science tells us that we may find the solutions to these complex social problems in early childhood, when the architecture of the brain begins to form. Brain architecture is built over time and shaped by experiences, starting in the earliest years of life. The most important experiences come from the environment of relationships that interact with each child: parents, extended family, and caregivers of all kinds. But serious adversity early in life can disrupt healthy brain development. Both brain architecture and behavior are increasingly difficult to change as individuals get older. So what happens early matters for a lifetime. Now imagine you can take action to improve the lives of children and the quality of life in this community. Where and when would that action be most effective? The links between policy, parenting, and brain architecture become much more clear when we can see how formative events in family and community environments affect child development. For example, policymakers want to make their communities safer, or improve children's learning, or reduce the cost of chronic health problems. A child raised in this environment may experience lower levels of stress and more opportunities for learning. That leads to sturdy brain architecture and a healthy stress response system, which prepare the child to achieve higher levels of literacy and other skills early in life. and later leads to improved school achievement and decreased dropout levels. Positive early experiences can also reduce levels of obesity, diabetes, and heart disease. Increased health and education levels can have positive effects across society, like reduced crime and increased income and tax revenues. Policies affect both individuals and communities, so making wise choices that support early brain development can improve health, behavior, and learning throughout life.
I hope that you enjoyed the video. I like this video a lot, and the work from Harvard University, from the Center for Developing Child. It is not specific for pediatric dentists, but is related to general experiences. But we know that in pediatric dentistry, the experience can be positive or bad, can be a positive or a bad reference for physical, cognitive, emotional, and social development. So it is very important to be conscious about that and responsible. Cognitive. Sorry, the computer. Okay, the computer is syncing. Sorry for the delay. Yes, I know. Here the computer is maybe because of the video. I don't know. It's taking some time to pass the slides. I don't know why. This didn't happen during the text.
Okay, doctor, you can reopen the presentation, please. You can close it and reopen it.
Okay, sorry for that. Wait a moment, please. Ivanov?
Yeah, doctor, I'm with you.
Yes, I'm sorry for but maybe I need to restart the keynote because it is not answering. Okay.
Okay.
Sorry for that.
That's okay.
And now I will open your time the keynote. Okay.
Okay.
Yes, now it's opening. I hope don't have more problems with the streaming. And
No, it's
let's share now. Okay, let's continue. We were here. I have other videos. I hope that will not have this problem. Okay, so sorry for that. Cognitive behavioral psychology is a specialty in psychology, as an experimental clinical approach, follow the principles of human learning and development and the theories of cognitive processing, and promote thinking and behavioral changes. It is problem focused and action oriented. The basics of cognitive behavioral psychology is the interaction between thoughts, feelings, and behaviors. So a thought creates a feeling, and then can create a behavior. So every behavior is related to feelings and thoughts. Is the dynamic of cognitive behavioral psychology. Why dentistry represents a cognitive behavioral challenge for children? So we have general challenges and specific challenges. Related to general challenge, we have the age. Children born with impulse rather than coping skills or competencies, and age also is the unfamiliarity is also related to age. Small children usually don't have the same facility to interact, to integrate in an unfamiliarity and ambience and different people. Parental competency is also a crucial point, because some parents can help children better in the dental setting, and others don't. A competent parent behave in a consistent manner, set limits and controls to children's behavior, has positive emotional interactions, contain child fears and anxieties, and encourage child independence and social skills. But on the other hand, parents that behave in a consistent manner, few limits or boundaries for children's behaviors will not help. Parents that overly attentive or inattentive, and they are emotionally inclusive or distant, and parents that are negative or punitive, parents that inhibit social skills or autonomy, that have little responsiveness to child's development needs, will not help in the dental setting. Children has also fantasies, anxieties, internal dangers. These are associated with fears of loss of mother, fear of bodily hurt and helplessness, harm and attack. So the dental scenario sometimes can activate these internal fears, can activate these internal dangers. So sometimes the reaction of the children to the dental procedures or to dental instruments can be not a real or a reaction to the real world, but this scenario, what it is doing is activating the internal fears, the internal anxieties, and this that children is living sometimes. Vicarious learning is also something that we need to lead with that. Parents, brothers, colleagues, all the society, sometimes the media, even health professionals can pass wrong message to children. A lot of children come to the dentist for the first time, and they come with fear. Somebody gave the wrong information, and we need to live with that. Personality is also an issue that can also affect the children behaviors. Not only fear can affect behaviors and non-collaboration, but also some personality traits like impulsivity, like general fear, like high hyperactivity, or low attention level, low verbal intelligence. There are a lot of personal traits that sometimes are associated with the lack of cooperation and that are not associated with the fear. So I'd like to show 2 videos, and I hope that we'll not have the same problem about 2 children that they want to talk to you about what they think related to pediatric dentistry. The first is an impulsive child.
My name is Speed, Johnny Speed. I am 8 years old, and I don't have the patience to sit here talking about pediatric dentistry. I'm intelligent, and I can understand everything around me. You think I'm impulsive, right? So all I have to say to all of you, you are all crazy if you think you're going to put those in my mouth. My mouth is just fine. I don't need that. I don't care. I don't want to think about the consequences of my actions. So I'll just give up. So do you want a collaboration, right? Don't get mad at me, please. It will make the situation worse, and it will not help. Another tip? Let's see. Don't give so much information at once, and let's work together, one step at a time. And I like positive reinforcement for each and every step, one by one. And be creative if needed. The thing I don't like is inconsistence. And if you want to work on me, a good way is relaxing conversation.
Now I will show a video with a shy girl that shows different way to think, way to react, way to interact.
Hi, I'm Didi. This moment is not easy for me. To talk to strangers and be the center of attention is really not for me. It's like that in your clinic, right? It's not because I don't like you. I'm just shy. So, when you see me for the first time, don't give me a lot of attention. I'd rather you talk with my mom first. I will listen to everything very carefully. And if you are okay with my parents, I will be okay with you too. Really. I hope you don't call me out on my shyness. I will be more comfortable if you give me a sense of control and some choices that encourage my acceptance. Tell me how beautiful my smile is and how the procedure will help my mouth stay healthy and beautiful. That would be great for me. My last advice? Try to be a mirror for me, doctor. Express your emotions. It's much easier for me to do the same. If I can talk about what I'm feeling, I can control emotions and my behavior. I'd also like to say one last thing, okay? Is Patricia Gaton here, right? I want to say that you are a special person. Thank you. Gracias.
Sorry for another small problem. I think we'll fix in some seconds. Yeah. No. Yes, I will now wait a moment, please, because yes. Now I think yes. Now it's good.
Yes, doctor.
Sorry. So, related to specific dental challenges, we have first the mouth significance. children, babies born, and they connect the world with their mouth as relational functions and survival functions is a part, even for adults, it is a very sensitive part of the body. It is a private part of area, and it is has a lot of importance for children. Another question related to a specific dental challenge is the awareness of dental problems. Children that experience pain and some kind of suffering usually will have more, will represent more challenge for us. And to do our treatments, we need some kind of sense of rules, and we need time to make the treatments, and also sometimes to prepare the child. And we have not too much time for the possibilities that children offers to us, and for the complexity of the treatments. And also, dentistry really represent a challenge when cause pain, when cause discomfort, when do we need to infiltrate the body, when do you need to reduce a tooth with a burr, or even when children see blood. I think also that the designs of the material doesn't help. Function and design usually are intrinsically connected. The same happens with the dental instruments. All dental instruments have their own specific design due to their function. And for that reason, sometimes children feel anxious when they see a forceps or a syringe, because their design alerts to the function and their invasivity. I think that is very important in the future to take care about this and to produce some kind of instruments and materials that are children friendly and don't alert before the invasivity, that sometimes children are aware because they interpret the design of the materials. And the invasivity usually can increase some kind of pressure. Not all the treatments, not all the procedures can create the same pressure level, but when the pressure increase and when it's too much for the child limits, they tend to respond with a fight answer, a fight response, or a flight from the situation, or freeze in the situation. So this is the typical response to pressure, to the anxiety. But we talked about problems, we talked about difficulties, the challenge, that I think that is important to be conscious about that. But don't worry, approximately 80 or until 90% of the children have good behavior at the dentist. But if you want to overcome this challenge, we need to think in prevention. Prevention is always the best. And looking at the cognitive behavioral model, we think to prevent negative thoughts in parents and children, and also prevent negative feelings. I think that is the best way, looking for this dynamic to see prevention. And the first step in each intervention is the relation, the therapeutical relation, and we need communication skills. The therapeutical relation goals are the creation of an effective bond with empathy. Empathy is the ability to be intuitively aware of what another person is feeling as well as thinking. Empathy is in a therapeutic relationship will enable the dentist to identify and understand the needs of the child and family, and respond appropriately. The therapeutical relation goals are also to find a safety atmosphere in a way to achieve a collaboration, to achieve collaborative relationship and agreement on goals and tasks. And the therapist is very important. First of all, I think that a dentist, before and when treat children, needs to like to be with children, needs to be also genuine. For example, I like to say like that, I know how to be, I am myself with children, and also I believe in dentistry, I believe in what I do, and because of that I try to be present and contactful with children, and with words or without words, I try that children understand that I care about how they feel, and I understand how they feel, and give space for them to feel free and to feel as they do. So I think that every adult has an interior child, but also every child has adult competencies. So I think, and this is a point that that has a lot of discussion, and I think that the main goal in the relation and the dynamic of the relation is to achieve a space and to achieve a bond in a way that child can show in the dental setting their adult competence, but also we can work on that. And the adult competencies that are very important, in my opinion, for dental treatments that we can work and help children to grow on that is resilience, create self-motivation, positivism from difficulties, sense of security, and learn to lead with emotions and to trust in authority figures, and have a sense of autonomy and to be proactive for health behaviors. Communication is very important. We need to adapt our communication for children world, and you can utilize specific words to talk with children, to present our materials. Like, for example, the air blast we can call wind, the burr we can call brush, like the prophylaxis brush can be a big brush, and the burr can be a small brush. For example, when you utilize an high speed with water, you can do a shower, or even to make a paint with the shower. For example, the rubber dam you can call rubber raincoat, and pit fissure sealants, tooth nail polish. And for example, the extraction forceps, I think that is very difficult to find an alternative. The best name that it was a colleague that told to me, and I'd like to receive suggestions about the names that you can call, because to create a cognitive model is very important for us, and we can work all together on this. For example, to call to the forceps a mound of a bird, like a papagayo. I think it was interesting, because I didn't find any comparable word to do it. But non-verbal communication is very, very important, because pediatric dentistry communication is much more than words. The way you look to the children, your posture, your movements in space, the way you touch the children, can create a safety and trust environment. For example, I work in Belgium since 2 months ago. I had until now no problems with children. I have a high success rate and I'm not independent in the language, mainly because of non-verbal communication. We can achieve trust with the sense. It is something very important, and this experience in Belgium gave me more this understanding. And the environment is also important, because if child goes to to a specific environment that is made for them, they feel easily integrated. They want to be a part of that, and don't see in the design, in the design, don't see message that can make some doubts. So the design is also important, but it's not the most important. Not everybody has the possibility to have the most beautiful clinic, but the most important is the person. The most important is the therapist and the human side. And in every part of the world, we can do a lot of amazing work without the best conditions. And this is the most important. And now I will talk about the structure of the intervention. So, for example, I think as founder of Pediatric Dentistry Forum, we see a lot of clinical cases related to dental techniques, restorative, orthodontics, but we don't talk too much about behavior management. And I don't know if I have the right answer, but I think that our education related to behavior management is not very well structured. So it is not easy between people to talk about something that only touch the personal side, or touch too much the personal side. And I think to create a structure in a way that people can talk about models, I think that is very important for us in the future to improve our intervention. The therapy is very centered in the professional, but it's very important to have models and structures in a way that we can touch the same points of learning, in a way that you can learn with others, I think, and analyze the cases in a structured way. Usually, I try to do in this slide the structure of my intervention, the way I think that that make me have more success. First of all, I do an evaluation of children and parents, and this make me to do a case conceptualization, and then I will go for clinical intervention. I'll separate here the first appointment, the evaluation, case conceptualization, and also a part of clinical intervention, and the second appointment, the other part of clinical intervention. Related to evaluation, that is made through observation. Children enter the room, and you observe. You can take a lot of information, but you can also make an interview. You can also make questionnaires to children and parents. And during this evaluation, it is very important to know the past experience, the past dental and medical experiences, the child typical fears, the child typical behaviors in other settings, and the development stage. Because sometimes a child with 2 years old can have some kind of competence and personality traits that seems that related to the dental setting, they have more, this child is more advanced in a developmental stage. So it is also important to analyze the personality traits like shyness, impulsivity, autonomy degree, their fears, and the parenting styles, their assertivity, their security, their beliefs, and their expectatives. Because it is very important. Sometimes a lot of parents come and say, we'll do nothing to my child. But in 5 minutes, we'll show that is not like that. So we need to work with the expectancies. This is a table with a questionnaire that in these 5 questions, if the answers are in the right side, you can understand, or you can prevent that you will have a child with low behavioral controls. And in the left side of the answers, you can expect that the child will have more behavioral controls, because the parents can set limits, parents can control the children's fears, and it is a way that you can do before the appointment. You can make a questionnaire that so before the child enters, you can take this information. So after this evaluation, it's time to understand the limits and limitations of the children, their strengths and their possibilities. So you'll design in your mind an intervention the way your road. For me, every clinical intervention follows some principles, and the principles I follow are to become treatments acceptable and predictable for children and parents. And I only work on what children see and feels. I don't give information that children will not feel or will not see. And I try always to monitorize and prevent negative thoughts. And the major importance in dental treatments and in pediatric dentistry is to do treatments free of pain. Is the most important, because is the real challenge that make dentistry difficult, and create self-intrinsic motivation and work, as I said, on children personality traits and specific personal children traits, and promote their capacity to learn and grow in the experiences. So we have a big box of tools with different cognitive behavioral techniques. The first I will describe as psychoeducation. That is a process of providing education and information. And usually this psychoeducation helps children and parents better understand where they are, what to expect, and can help to construct helpful cognitions over the challenge. And usually this leads to increase compliance with treatments. What are the crucial times to do psychoeducation? For example, you can do before the appointment. You can send a letter to the parents with behavior orientation, or you can say after the evaluation. You can orientate after earn the trust of the parents. They recognize your authority and your expertise. You can help them to find a helpful way to behave, and in the end of the beginning of each appointment, you can also do psychoeducation. Cognitive reconstruction is a different tool, because work on cognitive distortions. Usually, when the children comes with the past negative experiences and they relate the experience, sometimes they have cognitive distortions. So when they talk about that, when we can work on that, it is a reconstruction about the beliefs, about the expectancies, about the experiences, and also increase a positive self-talk, is a cognitive changing. And another tool is systematic desensitization. I think that is the tool that we use a lot. So you can see in the graphic, in the left side, we have the actual point and a goal, and in the right side, the systematic desensitization process. We have the goal, but we will become to achieve the goal in different levels, in different steps, to make a hierarchy of fearful stimulus. And between each step, we can utilize other techniques. So we do a step, we achieve an adequate response, and when the step is established, when the response is established, we do another step. This is a cumulative process, and when the child has reached the state of serenity, after being presented with the lower fearful stimulus, we present the other. So we do this hierarchy until to achieve the right response, the response that you want, the response that you need, and the response that children with their competence can achieve. Play therapy. Play therapy is crucial to work for work with children. Is the best way to prevent answers like fight, flight, or freeze. When you put play on it, the pressure will be shorter. Is some kind to lead with these answers and to prevent. Play therapy is the child language and relieve feelings of stress, as I said, and can help to learn more adaptive behaviors and create an identification space in the child. Feel free to be and to connect with us. Modulation is a technique that we, with the help of a brother or of a video or a toy, we can modulate children behavior. We can show them what to expect, what sometimes children have a fear of the unknown, and in that way they can see it. So it is a good technique for children feel a better sense of control. The distraction is a technique for children to become focused away the procedures, because if the child is focused in the fearful stimulus, so we'll have a bigger anxiety response. So it is better to understand. It is good to understand the focus of the child and to try to achieve in a way that children feel secure and trust to achieve other points of focus. Positive reinforcement is a kind of valorization that is attributed to the individual capacities and take a form of an incentive. The positive reinforcement can differ between children according to types and quantities, and it's important to have in account the individual characteristics. The way you talk, the way do you give the positive reinforcement it can be different between children, and usually the positive reinforcement will develop more self-confidence, and it is very important that the positive reinforcement be contingent on the performance. So it is usually related to the satisfaction of the objectives outlined, but can also be attributed to the effort, not only to when the goal is achieved, but also when the child show a positive and a genuine effort is also a matter of positive reinforcement. Provide information of the value of realization and competency, and show to the child how a success can be achieved, and create intrinsic motivation to desire for their own good. So voice control. Voice control is a deliberate alteration of voice volume, tone to influence and direct the patient's behavior. This is very important to prevent misunderstandings. Sometimes children are very sensitive or shy. We need to take care about the way we do the voice control, but it's very helpful because children feel secure about the information. Children feel the direction, and to changing the voice volume in an assertive way, and our tone will help children to follow the directions. Relaxation is also important. Sometimes when you understand that children is becoming a little bit anxious, you can stop, you can make some breathing exercises to control their anxiety, and in a way to lead with the procedures, to lead with the sensations is something very helpful. Sometimes it's important to enhance children controls. When the child is not very well secure with the treatment, with the situation, if you give them the sense of control, like up their arm, or give a toy that makes some kind of noise. So it's different ways to give control. And the timeout is a different, because it's not for enhanced children sensation of control. is to use before a situation that you understand that will be problematic. So, or for example, for children rest is not the same that enhanced control. Usually I do it without children perceive that I did because of them, but I understand that I will have some kind of situation that I don't want to go forward, and I do a timeout without children understand that I'm doing because of that. I don't give the sense of control. And physical restraint has not too much space in the modern dentistry and in a lot of countries, but I think that sometimes, I rarely use, but I think sometimes can be an helpful tool. For example, children without limits, when they have parents with a lack of assertivity, and when children have some specific personality traits, and after psychoeducation, parents understand that, and sometimes they relate other problems that they have in other settings, and they find an opportunity, and they find in us a way to learn. So the goal of physical restraint, and usually I only do in smaller childs, but rarely, I will show in the end a video that I did physical restraint. And I only do it in the preparation phase, not in the treatment appointment. Only in the first appointment, when the point is not achieved, and I only do it without aggressivity and without the presence of a fearful stimulus. It's only a behavioral tool in specific situations with the parents, not consent, but when parents really find an opportunity. For example, sometimes I have problems with children to eat the soup, to brush their teeth, or even to do a lot of activities. So, and they find an opportunity space to change even themselves. But we talked about cognitive techniques. I was a little bit descriptive, but cognitive behavioral psychology is not a box of techniques, but an architectural work. It's very dynamic, and you cannot. Sometimes you cannot only do one technique. You are doing in a few time, do 2 or 3 techniques. You are working 2 or 3 techniques. Is a construction that you do, and your understanding, your deep understanding about children, and to understand what you can do with the children is the best way. And so it is not a box of techniques, but an architectural work. And because of that, I think that is important to be analytic, to understand the children and your goals and your limits and your possibilities. So I will give some tips, exercise for you that you are beginning your dental practice. So let's start with the relation. Relation is the first step. Sometimes children enter and they are not open to relation, to interview or conversation, because they are afraid or too young, parent dependent, or too shy. So when you see this child for the first time, respect the space that child gives to you, and you can start the interview with the parents. In this moment, you can give a toy, a puzzle, or a video to the child while you interview the parents, while you make the relation with the parents, while you talk about anamnesis, the oral health prevention importance, behaviors, expectations about the appointment. And when the parents understand and create bondings with you, now usually the child will be more comfortable, and then you can start to achieve contact with the children, not talking about dental issues, but talking about general things like the video. You can interact with the video that you gave to the child and is paying attention, or like the toy or whatever. And also you can then show interest in their things, like the clothes, like the activities, preference or tastes. So, and try to find a genuine empathy. So this is a role to start dentistry issues interview. For example, another simple situation, the child is reluctant to sit in the chair. Sometimes it's too cold. So what I do when I see this situation, and before the children understand it, I sit in the chair or near the chair, and I will start to explain what will happen in the chair, what they can expect. I will show the materials in a way that when they go to the chair, they already have a sense of control what will happen in the first appointment. So when we sit in the chair, for example, we are doing modulation because you are passing trust in your chair, you are comfortable and confident in your chair, and this increases the children's safety. Other exercise is when the child is afraid to open his mouth. For example, in this exercise that I call it the glove balloon, everybody utilizes gloves and balloons. I will try to, with a simple way, this intervention technique and the description of this intervention technique. So the techniques are modulation, desensitization, and play therapy. You only need a glove and a marker. So you can start to show a glove to the child and ask her or he what is the glove, and even if you don't, if the child don't want to play, you can make, for example, a realistic question like, is the glove a plane, or this is a glove or a plane or a shoe? Usually the children think so stupid that they pay attention and smile, and they will react and will give you the right answer. And no, you can still surprise the children, insufflate the glove, and the glove becomes a balloon. Usually they smile, and you can continue asking collaboration for the game, and you start we'll start to draw in the balloon and ask children to guess what are you drawing. So you can start, we can do one more time an irreal question like, is this is a eyes or hamburgers? And then you can go for the nose, and then for the mouth, and then for the teeth. Usually they are helping you and they are answering your questions. And then you can ask to count the balloons, the teeth in balloon, and you can ask them how many teeth they have, 20 or 1,000, for example. Usually they tend to answer, and when they answer is some kind of permission to do it in their mouth. And if you go to the mouth, they will open the mouth. This is a simple exercise. For example, in this moment, you can also approximate the child touching when you are drawing in the eyes and asking. You can touch the eyes of the children, the nose, the mouth, and so on. You can also utilize this balloon to show the other materials, for example. Another simple thing that before to go to the chair to manipulate the mouth, the children's mouth in the chair, you can toothbrush. You can do a toothbrush activity. You can increase the interaction with the child, and you can manipulate child mouth with a familiar activity that they do every day. It is much more easy than do it in the chair, and you can do in this moment first parental separation. It's easy to become alone. The parents are near, but you are separating the child to the parent, child from their parents, and now you can make a first impression about the way they feel, about the way they interact with their manipulation, and you can do it fun before to go to the chair. Usually it will help. Other thing, we know everybody, the major technique in pediatric dentistry is tell, show, do. Tell, show, do. Before, in the first appointment, after the diagnosis, and after the treatment plan, I do a preparation for the next appointment. I utilize the materials that can be fearful, and I do exercise in a way to extend the limits of the children. I don't do only tell, show, do in the treatment appointment. I do in the treatment in the appointment before, and I can call you tell, show, simulation, do, because with simulation I can approximate the feelings, the response, and to work on the response. So usually, or almost every time, I already know in the first appointment during this treatment preparation how children will behave, because you are doing this exercise, and treatment will be previsible, and you know that if it's already acceptable, and if it catch the same point related to the treatment in the next appointment. So treatment, local anesthesia. I don't show the needle to the children. I only inform the child about the possibility to feel anything in the like a punch, but without explaining that is an injection. I simulate in these hands, in this finger, in this hand, and I do an intensive local anesthesia, massaging a dry mucosa with a cotton roll until to achieve a small blood point. I wait some few seconds. I continue the massage some seconds, and then I infiltrate only until the babble, 1 millimeter, and use only a drop of anesthetic, and wait some seconds, and then I do it. I increase the infiltration. I increase the infiltration time. So it is important to explain the numbness feeling. We can touch the area before the children to be worried about. So you can preview the sensation. You can touch the child, explain, to show a mirror, and say that the kid is sleeping, and go to, in the end, we'll hit an ice cream to wake up like a kind of magic. So here is some image. So I use a cotton roll. I do a massage. 1 minute, 2 minutes, until to achieve a small frictional lesion. And I don't show the needle. I use syringe as any other instrument. I use syringe like a mirror, like everything, because I have a SEM, that is an instrument of evaluation of children reactions. I don't have problems with the dental anesthesia infiltration, because they don't feel, and children are usually they already I already did exercise with other instruments, so for them, if they don't understand that is an infiltration, and I do it without pain and without seeing, I don't have too much explanation and to show the needle. So you see the blood point, I insert in the blood point, and sometimes children can feel a little bit, but not something that changes the behavior. But usually they don't feel nothing. So I'd like to show some advanced cases. This is a case of Nelson that you cannot show because of problems of connection and streaming. And the next case, I think Abanov will show the video, is the case of Jessica, that I start the first appointment with physical restraint. She's a sweet. It was an amazing case for me, because she had 3 years old. She came from other dentists. She tried a lot of dentists before, and in the end, she loved to go to the dentist, even after doing some invasive procedures. And so I will ask Abanov to show the video. I made a surprise to her, because I already had further control. So this was a case of, in the first appointment, that I utilized physical restraint, and but not. I think not every. Too few cases today are cases, in my opinion, for physical restraint. So I'd like to say some final recommendations. This is an issue that I study a lot, and my first recommendation is to, before to try and when you treat children, try to analyze your own thoughts, your own expectancies, and analyze your behaviors related to your results. And another thing that don't don't say that children are a surprise box, because they are not a surprise box. With time, we'll predict the behavior. You'll predict the behavior. And another exercise that I think that is important to do, that I did, is always try to understand, analyze and understand the whys. Sometimes you don't achieve the right answer today, but some months you'll achieve an answer. And try to make this exercise. If you have an insuccess with the child, try to reconstitute in your mind the case, try to visualize other possible techniques, other possible interventions that you could do with your experience. Usually this kind of exercise will find hypothetical alternatives, and is good to improve your success, because when you see the road, usually it's much easier to achieve there. And the study, I also like to say, to study children cognitive behavioral psychology. I studied in a post-graduation program for psychologists, and pediatric dentistry is a big 3D interactive world with cause and effects. It's not only techniques description, is a dynamic process. And for me, pediatric dentistry is the most complex and difficult field in dentistry, because there are a lot of information. For me, it's my opinion, I'm a pediatric dentist, okay, but I try to do this analyze in a very critical way, not only because I am a pediatric dentist, but I think it is a complex field, and I like that, and it's why I also like a pediatric dentist, because in the beginning what's very difficult to treat children without experience, and to see insuccess and children crying. For me, it was very, very, very difficult, but to work with children gave me too much in my life. I like their energy. I like to be helpful, and is a kind of interaction very enjoyable. I'd like also to say to you to join Pediatric Dentistry Forum. Even you can share your cases. We are not critical. I tried since the beginning to become a respectful community, and everybody feel free to ask some doubts and collect opinions. And I'd like to thank especially to Mr. Havanov, and I don't know him personally, but I already know him some years ago, and I desire all the best also for Natalia Starr, and I hope to see you soon. Thanks and regards.
Thank you, Dr. Antonio, for your great presentation. And now we are waiting for the questions of the viewers. I see many people are encouraging you and thanking you, Dr. Antonio, for your presentation. But till now, we didn't receive any question. So yeah, there's somebody asking about the output of this presentation, Dr. Antonio. You can give them the output afterwards. That's right.
Sorry, I didn't understand that one. Could you repeat?
Sorry. Okay. Some people are asking about the output or the presentation itself. You can share it with the people or not?
Yes, but don't you share the presentation in YouTube?
Yeah, the video will be saved on YouTube to be watched anytime later, but I think people are asking about
yes, of course. Everyone that wants my presentation can send me an email or by message can have me in Facebook, and I will send to them the link of my presentation for sure. And feel free to ask if you have some kind of doubts in the beginning with your patients. Feel free to ask me, to maintain conversation. For me, it is a pleasure. When I began, I had people that helped me to in these roles. So feel free to contact me and share your thoughts.
Yeah, that's amazing. So anybody else want to ask Dr. Antonio any question? So I think we have waited enough. So thank you, Dr. Antonio, for your presentation. And I'd like to apologize for you as our ISO, International Scientific Officer, Natalia Savkova, is ill today. So she was unable to be with us today. Yeah, we have a question. As general dentist, in case of treating a child with who is difficult when it choose to redirect to a specialist, a pediatric dentist. So somebody asking about what's the exact time or what's the appropriate time to refer for a pediatric dentist as a general dentist when you.
I think from the beginning, I think that you need to think the best for the children. And I think you need to understand your role, not as a role that will take some time. I think if you see that you don't see the road with this child, you can refer them, and also you'll learn with this child, and maybe with the next one will be better. And don't force some situation that you don't believe, that you understand that is too difficult for you, and that is evident that is a really difficult situation. You don't need to learn everything in the first moment. The most important is the roles, and we will achieve some kind of success. I hope you don't achieve no one in success, but can happen. And if it happens, try to do the best for the child and learn with the situation. And we'll not need to solve every case in the world. And in the beginning is a little bit more difficult maybe, but try to every case, and many with the insuccess case, try to understand and to improve is hard, is a little bit hard, but it's the best way. And refer in this point that you see that is a difficult child, and in a way that the only related to this question, that is a general question, I think that I have to say this, but if we analyze the situation, the whys, the concrete situation, your behavior, the child point, of course, I could give other instruction for the next appointment, but related to this question and you are beginning, I think that is important to have this in mind. This is my opinion.
Okay. Yeah. Another question. When you cannot cooperate with the child, should we take her of the chair or for a while and then try again at the same means?
Yeah, I think the best is the prevention. But if you understand and prevention and the quick understand of the situation, and in this moment, yes, for sure, you can do a timeout. You can increase, and as you asked very well, can you go to the share out of the share and do some games? Yes, you can increase the relation. You can increase the relation, and the early identification of the situation is very important. Because if you go too much forward, sometimes in the difficult child, it's difficult to create the relation. You can do it. Sometimes children need more appointments, but the recognition of the difficulty, to make a timeout, to rethink of the case, to rebuild the case, rebuild the empathy, increase the confidence, and then explain better, work on with the techniques, modulation, systematic sensitization out of the chair, and then you go. I think it's better that to achieve any success.
Yeah, that's good. Okay. Thank you, Dr. Antonio. And we have another question. Could you explain how do you hide the needle with a cotton?
Yes, usually I insert, when I use a regular syringe anesthesia, I insert the needle in the cotton roll in the needle, and when I approximate to the mouth, even inside the mouth or near the mouth, I take out the needle without children understand that I'm without the cotton roll, of that cotton roll is out. I have some videos that I could not show about this. But it's easily, sometimes in the beginning, can be not be so perfect, but it's easy to avoid this visual image. There are other professionals that shows the needle. I don't like to show the needle. I don't need. I try to work in feelings and what children see, and trust with the mouth manipulation. So if you don't see the needle, you don't need to alert for that, and you can take out the cotton roll inside the mouth or even near the lips. And in the end, you take out the syringe, and the mouth, they don't understand. With the time, we do this so normal that you don't give space for supposition. But this is my philosophy. I think it's also important to learn with other professionals, other techniques. It's the best way. I still do. This is my philosophy, the way I work, and I can say that I have a good success rate. So, but this is the way I work.
Okay, thank you so much, Dr. Antonio. I see someone are thanking you in Portuguese. I can't say it. Yeah. So it's okay. So till now we don't receive any more questions. So thank you everyone for your time and your presentation, and thank you so much, Dr. Antonio, for your great lecture.
So for meet you, and
we hope
all the best.
Yeah. Okay, you need to say something?
No, I was thanking you, and nice to meet you, Abanov. It was was nice to meet you.
It was my pleasure, Doctor. Thank you all for your time, and see you soon in next webinar.
See you.